we're going to talk about this awesome case we've got today. Go ahead and take a second to read this, and then we'll get into it. Pause the video now. Okay, assuming you've already read the question, let's get into this. We're going to get my highlighter ready because highlighting is a great way to actively read questions. So I always first start with the question part. Which condition is the echo most likely to detect? So we're getting an echo. This is probably a cardio question. I then like to jump into the answer choices. So briefly, I'm looking through here and it's all cardio, just like I thought. Now let's go back up to the top. We're going to read through this vignette quickly and highlight anything important. We have a 12-year-old for a routine sports physical. So it's not like he came in with signs or symptoms of something pathological to begin with, probably an incidental finding. Looking through the vitals, everything looks regular. Nothing's jumping out at me. Physical exam, here's where we hear our heart murmur between the first and second heart sounds. So if we're thinking first and second heart sounds, let's move over here for a second. We've got our S1, and then we've got our S2. Remember, S2 is split into an aortic and pulmonic valve closure. Here's S1, and S2. S1 is closure of our, which valves? I feel like Dora the Explorer. That's right. Closure of the atrial valves, our mitral and tricuspid. This is our isovolumetric contraction when this valve closes, and then we start to eject fluid. So this is our systole here. So this part here is all systole. That's what we're hearing between our first and second heart sound. So it's a systolic murmur, worsened when he stands up and while asked to breathe through a narrow straw. Really strange question, really strange thing to do, but these are pathognomonic for potentially two pathologies here. So boy standing up, we're thinking there's going to be less blood returning to the heart because gravity is causing blood to pool in the lower extremities. We've got our decreased venous return. Next, while breathing through a narrow straw, that's just another way to say Valsalva. The Valsalva maneuver increases pressure in our chest because we're trying to breathe against a closed glottis. A lot of weightlifters do this to help brace their spines while they're preparing for a heavy lift. We'll do the Valsalva maneuver or something similar when we're trying to look for murmurs, or if we're doing a vagal maneuver for a supraventricular tachycardia. Here, obviously, we're looking for a murmur. So Valsalva increases pressure in the thorax because we're bearing down on all the air in our lungs without letting any of it escape. So increased pressure in our thorax, which means we decrease the amount of blood returning to our thorax. Remember, blood moves from high to low pressure. If we have a lot of high pressure in our thorax, we're not going to get any venous return, or we'll decrease our venous return. So two maneuvers that decrease venous return with a systolic murmur. There's two things that should jump to mind immediately: HOCM and mitral regurgitation. These are kind of the two exceptions for murmurs that actually increase in volume with decreased venous return or with decreased blood. And it's very important to know these because they are the exceptions. So HOCM, essentially, there's something in the way of our heart. So if we were to draw out HOCM over here, we'll see that if this is our aortic valve, then this is the left ventricle with our septum here, we'll have something large and obstructive in the way of our left ventricular outflow tract. So when blood tries to make its way out, it runs into this obstruction, can't make it out very well. However, if you were to fill the heart with even more blood, here's your aortic valve, here is our left ventricle. Now it's engorged because it's full of even more blood. Now you'll notice that the obstruction has actually been moved out of the way because we have even more blood in the left ventricle. It actually pushes the obstruction out of the way. So it decreases the sound of the murmur. So anything that decreases venous return decreases the amount of blood in the left ventricle, which gives you this picture here. And that's why HOCM would increase with a decreased venous return, as in this case. Mitral regurgitation is similar, but slightly different. Here's how I like to think of it. If this is our mitral valve, that means we've got our left ventricle over here, right, kind of on the side of where we were before. Here's our aortic valve. When you contract, since this is really a floppy valve, the blood is going to be able to go right back out, as well as leave through the aorta. However, if you fill the left ventricle with more blood, I like to think of pulling this mitral valve even more taut than it was before. So remember in this first picture, it's kind of loose and it's able to regurgitate. But when you fill the left ventricle more, you stretch the mitral valve a little bit and it actually makes it a little more taut. So there's less blood that is able to bounce off. Yes, there's definitely going to be a little bit that makes its way through, but not as much. So there's more blood able to move through the aortic valve, and so there's less murmur. So let's take a look at our answer choices here. Aortic constriction, that sounds kind of like an aortic coarctation, which is not what we're talking about. Atrial septal defect, no. Mitral valve displacement, not quite sure what mitral valve displacement means, if I'm being completely honest with you, and that's okay. You're not going to know what everything means when you read through these questions. Maybe that's referring to our mitral valve prolapse that we just discussed. So maybe, I wouldn't rule that one out quite yet, but these others, I think we can cross those off. D, thickened interventricular septum. So that's our HOCM that we talked about, our hypertrophic obstructive cardiomyopathy. So I wouldn't cross that off. And then E, this is a ventricular septal defect. So nothing like what we were talking about. So we're down to 2. If you get in this scenario where you're not quite sure which one it is, but you do think there's some validity, I would pick the one that's most common. In a 12-year-old boy who's asymptomatic, I would bet that D is our correct answer here.